another episode of the NLN podcast, Nursing Edge Unscripted. We are your hosts for today's episode. I'm Dr. Kelly Bryant, and I'm joined here by my colleague, Dr. Raquel Bertiz from the National League for Nursing. In this episode, we will be talking about a very hot topic and a timely topic, nursing education's continued drive for excellence and competency-based education. And this conversation is going to focus in particular on clinical education. Before we dive into the full conversation, let's share some of our reflections right after the taping.
We're always looking for practical solutions on how to operationalize CBE. And obviously from the conversation, they do offer like concrete steps. So how do you do this?
Yeah, that was a very, very informative podcast. I really enjoyed speaking to Rose and Stephanie. What I loved about it the most was that when they started talking about the process, it wasn't that they just jumped into creating this tool, but the fact that they had this 2-day workshop where they kind of mapped out their curriculum to figure out which competencies or outcomes belong in, whether it's didactic, clinical, or simulation. And then we're able to come up with the behaviors and this tool. I think that was an important first step. And the fact that they also involved faculty, so the faculty kind of owned it, and then even had student input. I thought that was a great way of making sure that they get that buy-in.
Right. I like their emphasis on involving clinical instructors, and that clinical instructors are vital to any nursing program implementation and how they need to be prepared. And I think that brings us back to many of our issues with clinical instructor preparation, where we ask them to, okay, go ahead and swim.
But also, it also gave us a new perspective on how to conduct clinical evaluation, because let's face it, a lot of us, at our universities have this long 10-page tool with the MET, partially MET, and all these outcomes, which are like they were saying, are very broad. I love the fact that now it's based off of competencies and students add their input and they're able to identify, the behaviors that met that competency, and they have an input along with the faculty. So again, having more of that student-centered focus, I think is where we need to move when it comes to clinical evaluation. So it's nice to have a new model, a new way of thinking, approach to clinical evaluation, because I do think we've been stuck in our old ways. Let's turn from our reflections to the experts driving this important conversation. Our guests today are from Widener University School of Nursing, who have developed an innovative model in which students use a competency-based clinical evaluation tool each week as part of their clinical evaluation. Our guests today are Dr. Rose Rossi, Professor Emeritus, and Dr. Stephanie Jeffers, Associate Dean of Undergraduate Programs at Widener University School of Nursing. I want to welcome Rose and Stephanie. Thank you for joining us today.
Thank you for having us.
Thank you.
All right. So I'm just going to dive right in and start with, tell us a little bit about how you came up with this idea to start this competency-based assessment in the clinical setting. Give us the background on that.
Well, I think the first thing that we realized at Widener was we wanted to get all of the faculty buy-in as we were moving to the new AACN Essentials. So this really started by us having a full faculty meeting and workshop where we laid out all the domains and all the competencies and all the sub-competencies. And we asked our faculty to map where all of these occurred in each of their courses. And then, so that was sort of part one, but part two, then we said, what does this look like? What does this look like for your students based on your courses? So asking faculty to really begin to think about this from a competency perspective as opposed to just the knowledge perspective, I think was a good jumping point. And Steph could really talk about her own course, which is where she did a lot of this work.
Well, I would like to say that when Rose said that we mapped everything out, we literally mean mapped it out. There were poster boards, papers, we had post-it notes so that, we could tag different areas, different domains, what goes with which competency. And the faculty would write down on each of those slips of paper behaviors that were associated with the competency that they would expect students to achieve competency in by the end of the semester in clinical. As far as the courses, at the time I was faculty in both junior level and senior level medical surgical nursing. And so with our faculty that taught in those courses, we came up with behaviors that were associated with each domain and then posted them on all of the corresponding areas on the map.
The other thing that was really nice as we did this is that we broke out which of these behaviors would we want to measure in clinical, in simulation, and which of these behaviors would we measure in more objective ways, objective testing. So having faculty really begin to break that down, I think helped put it in perspective for them and then for us. So that was really step one. What this did, I think, was help the students then own that this behavior, these behaviors were theirs to create and theirs to develop. And it wasn't, I'm just going to sit back and be a sponge. It was, oh, I now have to seek out opportunities to try and meet this behavior. And I think that really helped engage the students in a way that were sometimes a little more passive than we would have liked them to be.
That sounds very interesting. I'm pretty sure that we're always looking for more student engagement. And from what you've said, it sounds like a lot of things you have done to get to where you are right now. So I'm curious, what were your biggest challenges with implementing this new approach?
I would say the biggest challenge was educating clinical instructors. So we had to present it to them as a new instrument. And let's be honest, everybody has difficulty with change. So just providing that education and saying, look, this is how we're going to measure competency. And then we provide examples under each domain. So for example, if somebody needed to meet interprofessional collaboration competencies, how did they interact with the interprofessional team? Did the student describe interactions in the clinical setting with the patient? And so we just had to provide that education to the clinical faculty. Myself, I was a course coordinator for junior level medical surgical nursing when we implemented this instrument. And I provided a lot of support because sometimes the clinical instructors weren't sure if they were doing the right thing or providing the right feedback to the student. How are they evaluating what the student is writing in their instrument weekly? So at the beginning, it was a little difficult, but they sort of picked it up pretty quickly. And the students also, I will say, initially they were focused on tasks and skills. Today I did a Foley insertion. Yesterday, I took vital signs. Whatever the skill was, they were mostly focusing on that. But with some prompting from the clinical instructors, the students began to really reflect. So when you're reflecting, you're thinking about what you're doing. You're not just doing a skill. And by the end of the semester, I would read some of these clinical evaluation tools just to make sure that they were completing them correctly. And it really seemed like the students had pride in what they were doing now because they're like, oh, I did this for my patient. My patient had difficulty breathing and I assessed them, I changed their position, or I talked to them if the patient was having anxiety. And it seemed like they were really more invested in their education as far as completing behaviors and thinking about what they're doing at clinical.
The other challenge we had, which I think was interesting and we didn't quite anticipate this, was the use of technology in our learning management system. Because ultimately what we wanted was one document where students could see their progression each week. And that was really difficult to do because we wanted one document where they could write their under their behaviors each week or under each domain each week, what they did so they could see it. And then faculty could comment. And we couldn't quite get there with our LMS. So we ended up having to be a little bit more creative in how that happened, because we wanted our instructors to be able to say, oh, on week 1, this is what the students said when they addressed this behavior. And on week 10, this is what they said. And you could see the growth over time. So that was a little bit of a challenge that we tried a couple different things, and we were doing those things even before we rolled this out. So we had a number of our faculty who were clinical, who were the students, and I was the instructor, and we'd be like, fill this in and let's see how this goes. So if I had my wish, I would figure out a different LMS system where this might work a little bit easier. But I think what we have is workable and usable, and we're not changing our LMS anytime soon, that's for sure.
Yes. So you just described a beautiful student-centered approach to learning, that the students are active in, assessing where they're at and how they're meeting their clinical outcomes, which I love. One question I have is a little bit more specific about the tool. So can you tell me a little bit more about what this tool looked like and how it was implemented? Meaning, did the students fill it out first and then the faculty kind of make comments to it, after the clinical day? And my other question is, and what happens at the end of the semester where there may be some gaps where the students weren't able to, demonstrate a certain behavior? How did you address that?
So the students needed to complete the clinical evaluation tool where they would address 1 or 2 domains per week. Obviously, you're not going to meet all of the domains every single time the students in clinical. So 1 or 2 things that really stood out to them. And so they had to reflect on what the behaviors were that were required or suggested for that particular domain, write some examples. And then the clinical instructor would then provide feedback on that. And there's a little rubric in the learning management system that says meets expectations or, needs improvement, that kind of thing. So if the student was too short with their response or they didn't provide a lot of detail, instructors would encourage them to do so for the next time. Or sometimes it ended up being more like a discussion post. So like there was conversation back and forth with the instructor and the student. It was more than the instructor just saying, hey, great job. It was the instructor sort of reflecting back on the student, what the student achieved, and identifying those skills and behaviors that were required for that particular competency.
And if there was an area where maybe the student didn't get an opportunity, but for example, they never encountered an ethical dilemma, the instructors would then say, okay, you didn't encounter an ethical dilemma, but what would you do if? And then they would give them a scenario or a situation and have them reflect on that situation. And that way, we weren't saying, oh, well, there were no ethical dilemmas that the students encountered, therefore we're not going to address this domain. They provided them, scenarios or opportunities to then discuss what would you have done if the scenario happened, or, what would you have done if you thought the nurse was giving the wrong medication? What would you have done if this event happened? And I think even in the feedback, which the instructors were wonderful in, is they would say, okay, so you talked about this. What would you do next time to further expand what you did? And giving students an opportunity to really think about those things differently and say, okay, you did this. This is great. This was a great start. What's your next step? What would you do after that? Allow the students to really begin to think about how they will continue to grow as a professional nurse.
Mm-hmm. That sounds really interesting. And I think I was going to ask you this question, but since you started on that note, my curiosity is all about, because you're doing this competency-based evaluation and use of the clinical teaching tool, how has your clinical teaching kind of like expanded, if that's the right term for that, or shifted? So because we're evaluating them this way, I'm curious, so how are we teaching them now to get there?
I think that clinical instructors are doing more debriefing with students now and encouraging reflection to assist students with identifying areas of strength and areas where the student might have to improve. And I think that is helpful to have a dialogue with the student because you're encouraging them to think about the rationale for their interventions or the rationale for a particular assessment. And that is really kind of the key to the competency-based education is you're doing more thinking than doing tasks and skills. So I think that this shift is more having more conversations and encouraging more reflective thinking with the students as far as the clinical instructors go.
And to add to what Steph is saying, one of the big struggles that clinical instructors often have is they don't want to upset a student by, giving them poor feedback, and they're not always comfortable giving that constructive feedback, or they don't quite know what to say. When a student has written something down like that and they have something to work on, it's much more collaborative. It's not, oh, me as the clinical instructor saying you didn't do a great job. I think it's helped our clinical instructors be more comfortable in their role and they're great practitioners. And sometimes what happens is you have an amazing nurse and now they've stepped into that clinical instructor role and they're trying to learn that skill set of how to be a strong clinical instructor. And this gives them the opportunity to learn how to provide feedback in a way that's positive and constructive and collaborative and doesn't feel negative and punitive to the student, because we never want a student to walk away feeling like, oh my God, my clinical instructor thinks I'm not smart and I'm not cut out to do this. And the instrument, I think, really helps that collaboration in a way that we didn't have before. Our other tool was truthfully, did you exceed, or meet or didn't meet, like this behavior. And then the other thing that we did, because these behaviors make sense, and I'm going to be totally transparent, our prior clinical evaluation tools were so vague. Apply the natural, social, and sciences and humanities to the care of the patient. And the instructors were like, what does that mean? How do I evaluate that? And now we have an instrument that's very clear. Like, we have very specific behaviors we expect our students to do. And so now they understand what their role is. The other thing I think that was really helpful in this when we met with all the faculty is that we were able to scaffold behaviors in a way so that we weren't double dipping. So, and it was helpful in particular in Steph's situation where she was in junior med surg and senior med surg. So the behaviors for the junior students were different than the behaviors of the senior students. And because of that, we could see the growth over time. And we're very fortunate at Widener. We were not in an environment that was very much a top down, everything comes from the dean rolling down. And because of that, I think engaging the faculty in this really made the difference, because without engaging the faculty, this would never have happened.
Well, we all worked together during that workshop. And so doing that together as a team, the faculty now own the clinical evaluation tool, especially for their particular specialty area. So they have the input into it. And so they know that this is something that they have helped to create. And so I feel like that helps them.
But that's the key to buy-in, to have people involved. They'll be more vested in it and they'll be more likely to implement it. So the fact that you went to the faculty and had to develop it, that was great. And also I love the fact that you involve students too, because it sounds like you even had the students, buy in. So if you ever want to implement something, yeah, those are the steps.
Yeah.
And we were really lucky because our sim faculty came, right? Then they got, and I also have to say, we have several of our faculty teach across undergrad and grad, but we've a significant number of faculty who just teach at the graduate level, and they came to the undergrad meeting with us to kind of give us support and come up with suggestions and help people who were struggling of writing, objectives and, behavioral outcomes. So I think what Steph is saying is right. That whole team approach, it made it better. And I was in Steph's role before Steph was in it. And I don't want to be the person saying, this is how you have to do things. Like that was just never my approach. So I loved the collaborative experience. And I have to say, by the end of day 2, we were tired.
It was exhausting.
Yeah, I was going to ask you, because when you talked about the process, how you mapped out everything to say, which outcomes are met in simulation, didactic versus clinical, how long did it take you? This was like a 2-day, full day?
It was 2 full days. So
Okay.
the first day, we literally were mapping out where things were, and then we were writing objectives that we were going to use in our syllabi.
Right.
And then day 2, we were then developing the behaviors everywhere where we said, oh, this lives in clinical. Then day 2, we were writing the behaviors. So by the end of day 2, we were all pretty done. And this was at the end of the semester.
Right.
So we were
It's in May. Yeah.
We were like, all right, we're done. We've had fun.
Right.
Excellent. So I believe when we had a prior conversation, you have just started this pilot. Was it this summer? Or
Yes.
last?
Yes.
So tell me, now that you have, a few semesters under your belt using this new model, what were those aha moments? Was there anything that surprised you, whether it's, logistically how you rolled this out, or when you looked at the data from this, the evaluations, was there anything that kind of, surprised you that you weren't expecting?
I would say for me, it was reading what the students were writing. Over time, it became more detailed, a lot of depth, a lot of emotion in it too, especially if they were dealing with situations that were challenging, such as, the patient was a rapid response, or there was quite a few students that had patients that were aggressive, or, there were safety concerns with the staff. And so they really addressed it in a very professional manner. And I was happy about that.
It's a good thing.
But also, like, the way they reflected on what they thought they needed to do as far as interventions or doing assessments really showed me their growth over a period of time. So I was pleased with that. This semester, over the fall, we have all of the specialties and med-surg doing their own clinical evaluation tools. So the specialties tweaked their own examples for competencies, or they use the same domains, but the examples would be different, for maternity or pediatrics. So I'm waiting until finals are over to review all of those. And I've requested feedback from faculty about, is there anything that we need to change in the language of the document? How did it work for your clinical instructors? And so that we can move it forward.
Well, yeah, all of this really sound exciting. And so if you could leave our fellow nurse educators with one takeaway about competency-based clinical education, what would it be?
I think actively engaging the clinical instructors, they're our biggest assets, and we want them to feel like they're a vital part of everything we do. And I think by actively engaging them in this process, they feel like they're our partners now and not just this, group on the side. Steph, what do you think?
I would say focus on thinking, not just doing, because competence is about clinical judgment and not just tasks or skills.
Oh, what a wonderful way to to end our podcast. I can't believe the 20 minutes went by so quickly. I feel like we can go on this topic. So I want to thank you both, Rose and Stephanie, for such a wonderful conversation on a very timely and important topic. I again want to say thank you for joining us and sharing your innovative approach to evaluating in the clinical setting. And for those of you that are joining us today, thank you for listening to our podcast. And we look forward to you joining us on our next podcast. Thank you and take care.
Thank you.